All right. So this angle theta is the Cobb angle. So this is how you will construct it. You know, we were teaching this question with the hope that one day they will ask a question in the form that they will give you an X-ray where there will be a scoliotic deformity. They will construct the angle on the X-ray and then they will ask you what is the name of this angle. So the name of the angle just is the Cobb angle. For that, what you have to identify first is the scoliotic abnormality. Second, how the angle was constructed. And third, in the answers, you have to mark that as a Cobb angle. All right. Now, each and everything, that means apical vertebrae is having a significance. The Cobb angle variations is having a significance in the management of the scoliotic abnormality. So this is one important X-ray finding that you have to remember. The second important X-ray finding is the Risser sign. It is the Risser sign. Now, what is Risser sign? Actually, just try to understand. You know what happens is, majority of the time, a scoliotic deformity is a developmental abnormality. That means with the development of the skeleton, there is a progressive scoliotic deformity. This is what the Risser sign is. All right. Now, before we talk anything related to or the importance of the Risser sign is discussed, before we talk about the importance of this Risser sign. So before we talk about the importance of this Risser sign, it is just important for you to remember what exactly is Risser sign. All right. So Risser sign actually is, Risser sign is for the visualization of the apophyseal fusion with the parent iliac bone. So it is to depict the apophyseal fusion with the parent iliac bone. Point number 2, why this Risser sign is particularly important? Because it gives you a prognosis of scoliotic progression. All right. It will give you an idea that whether the scoliotic deformity will progress or not. So this is what the Risser sign is. Now, before we talk anything related to Risser sign, let's have a discussion on the management protocol of the scoliotic deformity. So let's have a discussion on the treatment. You see, as far as the management of scoliotic deformity is concerned, we are going to talk not about the pathological scoliosis, not because of about the secondary scoliosis. We will be talking about the scoliosis which is happening because of the developmental abnormality. So in the form of the management, it is important to have a consideration of the Cobb angle. Imagine if the Cobb angle is 0 to 20, that means it is less than 20, then you just have to observe the patient. Means no intervention is required, you just have to observe the patient. But if the Cobb angle is from 20 to 40 degrees, then you have to go for the brace. All right. And if the Cobb angle is beyond 40 degrees, then you have to go for surgical management, or there could be a requirement of surgical treatment or surgical correction. Now, that surgical correction is based on multiple factors. There is a neurological compromise or not. What is the pace at which this scoliotic deformity is progressing? Then whether it is the requirement on the part of the patient or not. Fourth, the age of the individual. All right. So there are multiple factors on which this surgical correction is dependent on. So no one is going to ask you about the indications for performing surgery in order to correct this scoliotic deformity, because surgery is not related to the deformity. Surgery is related to its outcome, that what the patient would be able to perform once this abnormality is corrected. All right. Now, what exactly you have to look for are the braces in scoliotic abnormality. All right. So, all right, let's talk about the braces first. All right. What is the importance of the braces? Because this is something, not the surgical management. Braces is something which is likely to be asked from you in your examinations. So, as far as braces in scoliosis are concerned, the first thing that you have to remember that 2 points. Point number 1, which is extremely important, that brace in scoliosis is not used to correct the deformity. Brace in scoliosis is used to limit the progression of the disease. So braces in scoliosis, what are the use? The use is to limit the progression of deformity. All right. That means you are not going to use a brace in order to correct the deformity. Imagine the patient comes to you who's asking that, my Cobb angle is less than 40 degrees, or for example, it is 30 degrees, and I'm wearing a brace which was prescribed by you, will it limit the progression or will it correct the deformity? So you will obviously say that it is not used to correct the deformity, it will just limit the progression of the disease. Point number 2, that the indication of this brace is, that the indication of these braces is that when the Cobb angle is less than 40 degrees. Now this is already we have talked about, that in the management, that if the Cobb angle is more than 20 but it is less than 40, then a brace has to be utilized for limiting the progression of this deformity. Now point number 3, that what are the braces which we are using for the purpose. The first one is, so let's talk about the names of these braces. The first one is Boston brace. This Boston brace is also known as TLS brace. All right, TLS brace. That means thoracolumbo-sacral brace, where there is no immobilization of the cervical column. It is just a thoracolumbo-sacral brace, where there is no immobilization of the cervical column. All right, Boston brace. Now, what is the indication of this Boston brace? The indication of using this Boston brace is that when the apical vertebrae is below the level of T8, all right, that means when the apical vertebrae is either T8 or below the level of T8, so the Boston brace is utilized. Just use your head. If the apical vertebrae, that means maximally deviated, maximally rotated vertebrae is lower in the vertebral column, there is no use of immobilizing the cervical column, or there is no requirement of immobilizing the cervical column. That is why TLS brace is utilized. So that is Boston brace. Now the second one, or the second brace, is Milwaukee brace. And how this Milwaukee brace is different? Because it is CTLS brace. CTLS, as the name indicates, is a cervico-thoraco-lumbo-sacral brace, where the cervical, thoracic, lumbar and sacral column, all of them are needed to be immobilized. So what is the indication for performing or using this Milwaukee brace? The indication is when the apical vertebrae is above or at T7. So because the apical vertebrae is higher in the vertebral column, it is required to immobilize the cervical column also. So hope everything is clear related to the braces in scoliosis. Now only thing which is left to have a discussion on is the result sign. If we go back to the scoliotic abnormality, what all we have discussed, the first thing is the definition. It is a lateral curvature of the spine. Point number 2, what are the important X-ray findings? One is the construction of the angle, that is Cobb angle. And now you came to know how Cobb angle is important in management protocols for the scoliotic abnormality. Now the only thing remains is the result sign. As I told you, result sign is not used for diagnosis of scoliosis. It is used to predict the progression of the disease. Now that prediction of the progression of the deformity is based on the visualization of the iliac bone apophysis. So what you have written is the apophyseal fusion with the parent iliac bone. This is what you have to assess. Now the assessment would be based on, actually this assessment would be based on this basic understanding. Now just try to understand. Imagine this is the rough diagrammatic representation of the sacral and these are the iliac bones. Now in a child, in a growing individual, this iliac bone apophysis is there, which will fuse over a period of time. All right. Now this iliac bone apophyseal fusion happens from the lateral to the medial end. Now this fusion of the iliac bone apophysis, it starts from the lateral up to the medial end. Okay. Now imagine the patient's age is, for example, 16 years of age, or male, 16-year-old male comes to you and he is having almost around 3/4 of the iliac bone fused with the parent one. Iliac apophysis is fused with the parent bone. Only this much is left. All right. So what you will say to the patient, that because you are still in a growing stage, the possibility of the scoliotic abnormality that you are having right now is going towards progression too. That means to some extent the scoliotic deformity will progress because you are still in a growing stage. Imagine there is another patient who comes to you where the entire iliac bone apophysis is fused with the parent bone and he is suffering from a developmental scoliotic abnormality. Now in that patient, what you will say, that because of the developmental abnormality, the scoliosis which was progressing will fail to progress because you have achieved the skeletal maturity as far as iliac apophysis fusion is concerned. All right. So this is the importance of progression of the deformity in scoliosis prediction based on the Risser sign. So prognosis of scoliotic progression is assessed by Risser sign. So this is what you need to remember. All right. As far as the management is concerned, the treatment would be based on the calculation of this Cobb angle. If the Cobb angle is less than 20 degree, you just have to observe the patient. If the Cobb angle has progressed from 20 to 40 degree, you have to limit the progression of the disease by placement of the braces. The braces we have talked about are the Boston and the Milwaukee brace. In case of a child, instead of using these braces, a Risser cast is applied. All right. So in case of a child, instead of using these Milwaukee brace or a Boston brace, a Risser cast is used. All right, where the cast is applied involving the entire thoracolumbar region. So the difference in between Boston and Milwaukee, you already know that if the apical vertebrae is below the level of T8 or is T8, then the Boston brace is sufficient, while if the apical vertebrae is above or at T7, then the Milwaukee brace is required. All right. Now for beyond 40 degree, the management is not only based on the Cobb angle is more than 40 degree. The management would be based on multiple other indications, which you need not to go into the details of. So at least this much you need to remember under this particular heading, that is a scoliotic abnormality. Hope everything is clear related to this particular topic. I am again repeating that we were teaching this topic with a hope that one day they will give you an angle constructed in the image and then they will ask you, what is the name of this angle? Simple. The question was extremely simple. All you have to do was to identify a scoliotic deformity. Just to identify a scoliotic deformity, and the angle which is constructed over here will be the Cobb angle. Now, majority of the time they are going to construct it by projections of the two perpendicular onto these tangents, thereby reducing the amount of the deviations of this angle, although this angle and this angle will remain the same. This is what the Cobb angle is.